Hi, Kelly. Can you hear me okay?
Yes, I can hear you perfectly. And there's Dr. Levins. How are
Hello.
you?
Hi, David. How are you?
I'm great. I'm great. How you doing, Shashi?
Good, good.
We
So we got two more last minute guys filled in, huh?
Yeah,
Yes.
Tim said he'll still try to join in if he can, but he didn't want to, promise. So I just kind of had a backup. I, called a few folks and two of them volunteered. So we have more
About
than
that.
so.
Yeah, you have lots of you have a big team all over the country.
Yeah, I think it's a good forum. I really think it's a good forum for patients to hear directly from doctors, and
Yeah.
So, do you have do you want to just try, David, before we start, to share your screen so you know how to do it?
Yeah, no, how do I do that? Let's see. Let's see.
Haley, he's did you promote him to a panelist already?
Yes.
Okay, can you
Okay,
do you have to give
so-
access to him to share a screen, or can he just do it?
I
Nope,
just
it's-
press share. Just press
Yep.
share screen.
Yeah.
Okay. What's this? Screen recording, open system preferences. Oh, I have to allow it or something. Let's see. Allow. Will not be able to record the contents. That's okay. Oh, it's not for recording. Let's see. Later. You can choose to quit now or do it on your own later. Later. Privacy. Oh, maybe I just have to enter this. Let's see. Okay, advance. So now, desktop, share. Oh, okay. Did it happen?
Yep.
We can
Yep.
see.
Oh, good. So here's just a couple.
So maybe you just want to minimize the rest of the screens except the one that you're showing. You have a bunch of screens open.
I do. I have too many freaking screens here. Get rid of this one. Get rid of this one. Get rid of this one. That's there. Get rid of my email. And
definitely
get rid of this
that.
one.
Perfect.
Okay.
And now maybe you can maximize that and just save it and kind of minimize it down
Sure.
below.
Sure, I'll do that. Thank you.
Perfect. Yeah, you can unshare it whenever you want. So go back and just click unshare.
Stop share.
Yeah.
Oh, there you go. Okay, good. Stop share, 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 and stop share. Got it. Okay, great. Share and then stop share. Perfect.
I'm
Wonderful.
going to message our other two fellows to see where they are.
Yes. I do not see them in the attendees.
While you're waiting, David, this is Kaylee. She's our marketing department social media guru.
Nice to meet you.
Very nice to meet you as well.
Yes, I saw you hosting the last one.
Oh, nice.
First one or the last one, whatever.
Yes,
Yeah.
our first one. Awesome. We have 7 people already in here. So if anybody's listening right now, we're just going to take a few seconds to get our 2 other doctors in, and then we will get started shortly.
This is way past my bedtime, by the way, but whatever. I'll see if I can stay awake.
You have a nice home office.
Oh, thank you. Yes. And you're in your home office?
This is my son's office, actually.
Oh,
He lets me.
oh,
He rented it for me for an hour.
Oh, that was nice. That's it, by the clock.
He said if I go over, he's going to charge me.
Oh my God. He's going to lock you in. You won't be able to get out.
It's funny. So we are just waiting on Joseph Russo and Adam Schaffner to join us. Don't see them in here yet.
I just texted them. They should be joining any minute.
Okay, great.
He's there. Joe Russo is up there. You can make him a panelist.
All right, perfect.
Says JR up top.
Mhm. He is in, and so we're just waiting on Adam.
Hello, Shashi.
Hi, Joe. How are you? Thanks for joining.
Glad I could make it.
Yes, yes.
Thank you for asking me.
Yeah, absolutely, absolutely. We have David. David Levins is on. You can see him.
Hi,
Hello,
Joe.
Dave. How are you? Good evening.
Good to see you. I met you at Shashi's office. I don't know, was it a year ago, 2 years ago?
I think it was longer ago.
Yeah, a couple
I
years ago.
remember.
But you're in Newton, Massachusetts, right?
I am.
That's where I'm from.
What?
I went to Newton North High School.
I'm right down the street from Newton South, right across
Yeah,
Route 9.
we lived on Applegarth Street, right by Center and Commonwealth.
When you were going to school, do you remember a place called Fred's Country Store near Newton South?
You know something? I don't think I ever made it to Newton South. I didn't go the other side of the tracks. I was stuck on the Newton North side.
Yeah.
But
Where are you now?
I did make it up to Route 9, but I never got that much farther beyond there.
Where are you now?
I'm in South Florida.
Oh, I see.
I was there for high school and then college. I was at MIT and then
Wow.
New York and now Florida.
So you know the whole deal.
Yeah.
Fantastic. Probably a better choice to be in South Florida right about now.
Well, you know, my family, of course, said, no, stay in Massachusetts. And my wife's from Miami. So we said, well, we'll go for Florida.
I like it. It's a good choice.
Is it snowing already up there?
It's we actually about 2 weeks ago had 6 inches of snow, believe it or not,
Crazy.
on a Friday.
Wow.
On a Friday, I was flying out, but then it's been actually above average temperatures recently. So today was a little bit of a cold snap, but it's it's about as good as it gets. We were in the 40s today, so it's okay.
It feels like it's amazing. Today was an absolutely perfect day.
Oh, it's beautiful today. Yeah. We need to can today. 70 something, 75 is beautiful.
That's lovely.
Yeah.
Lovely. So what are we going to talk about tonight?
The liposuction and lipocontouring, I'm going to moderate it. I have a bunch of, common questions that patients ask. We did one of these back in the summer. Joe, you and I did with John Taylor, if you remember.
Yeah, I did.
But this is going to be more, question oriented that, I'm going to ask of you guys, and you both can discuss your thoughts, your opinions, so that the goal of this is to really give very good, credible, factual information to patients. So this is a patient-facing webinar, and so it's a pretty straightforward liposuction, body contouring kind of seminar.
Excellent. It's our sweet spot, right?
So Adam said he's going to be joining in 2 minutes. He just texted me. It's only 8:29, so I think we're all going to be right on time.
Okay, perfect. Perfect. So everybody that is currently in right now, just sit tight and we will start at 8:30 or 8:31 if he's going to be here in 2 minutes. So we'll wait. We'll be a minute behind.
Shashi, how are things going with you?
Good, Joe. Everything's going well. I don't know. Somebody just texted. Somebody just chatted. Kaylee says the volume is down or something. Is it mine or yours? I don't know whose it is.
Let's see. The volume be raised. It might be his personal volume that is down because I can hear everyone clearly. So I don't think there's any issues with Zoom.
Okay. Great. So it looks like maybe it's just somebody else responded.
Yeah, somebody just said their sound's fine too. Thank you, John, for answering that. Okay. Just gonna wait another minute here for Adam to join us and then we will start.
We had a good group sign up, almost 70 some people signed up, I believe.
Yes, so it should be a good one.
How did you advertise it? How did you let people know we were doing this?
Just social media, basically that's all. Social media and some, I think Symplast folks emailed everybody, but I posted on my social media outlets.
Mm-hmm. And Dr. Adam just joined us. He should be popping up soon. Okay, there he is. Right. Okay, there he is. Perfect.
Hi, Adam. How are you?
I was a minute late.
No worries, no worries.
All is well. All right. Well, thank you everyone for joining us. Good evening and welcome to our second Symplast Physician webinar. My name is Kaylee Lipka. I'm part of the marketing team here at Symplast. Symplast is a physician-founded company, as many of you know. So one of our main missions here at Symplast is to provide impeccable engagement between our physicians and their patients. So anything we can do to make that goal happen is our mission. We are also a tech company, so if we can facilitate these engagements through any modern tools, that's also our goal. So we will be doing that tonight and kind of talking through some new procedures and new tools that the doctors are using and how they're using their new tools and practices to kind of work in with this topic. This is going to be our second time that we've brought together our customers' physician base to promote really high quality education to our consumers and our patients overall. So this webinar is directed to our patients, and we have brought together some highly reputable surgeons that are here with us today as part of our service to the community. So we are really excited to be discussing the ins and outs of liposuction and lipocontouring. This webinar is powered by Symplast, but it is going to be moderated by our founder and chairman, Dr. Kusuma, who's with us tonight. He is actually a plastic surgeon first, so he will be able to speak to this topic very well too. And he is joined by some of his colleagues, Dr. David Levins out of South Florida, Dr. Joseph Russo from Boston, and Dr. Adam Schaffner from New York. So this is going to be very conversational. So if anyone that is joining us has any questions, please drop them down into the chat box and I will interject and let the doctors know any of your questions so they can be answered live. But that's it. And we can pass it over to Dr. Kusuma and start our webinar.
Thank you, Kaylee. This has been a really fun little project that we've undertaken. And there's a few main reasons for this. One is that, you know, in many cases, physicians are very good at talking to other physicians at meetings and such, but there's not enough meaningful engagement that good, you know, factual, well-trained physicians engage with the customer base, which is the patients directly and credibly on their terms and speak to them directly. And so we felt this is a great forum to do so. One main reason is that there is no bias in this forum because, you know, we're not promoting any type of device or any particular procedure. We are just literally talking about education and getting opinions from different physician colleagues from around the country. And so it's just not my opinion or my experience, but it's a collective wisdom. And that's how medicine is always practiced, so that we always discuss with each other. And I really want to thank Symplast, because Symplast technology affords us the ability to use all kinds of modern engagement tools. And many of the surgeons who are on the panel now are also on a common thread with me that, we discuss patient cases that are difficult or interesting. So this is all about creating a very valid network. Having said that, I want to introduce, the friends, really. They're first and foremost my friends and, fellow plastic surgeons. Dr. David Levins is a neighbor. He's right here in Colorado Springs. I've known him since I moved to South Florida in 2010-ish time period. He's an MIT graduate and Montefiore trained plastic surgeon, did hand surgery fellowships, and he's been around for a very long time in South Florida and has been practicing safe and responsible plastic surgery in South Florida community for a very long time. So I want to welcome him to this panel about liposuction and lipocontouring. The second physician on with me is another very good friend of mine. I met him, a few years ago through our journey through Symplast, actually. His name is Joe Russo, Dr. Joseph Russo. He's a Bostonian, trained at Harvard. He's been there for quite a long time. And one of the things that Joe does, Dr. Russo does very, very well is educate and train. As a matter of fact, he's got a forum called Aesthetic Mentor, and he trains a ton of people in Boston area to do responsible and safe injection techniques and non-surgical methods to deliver plastic surgery, cosmetic services in the Boston area. So welcome, Joe. Welcome, Dr. Russo.
you.
And another colleague of mine who has a common background as I do. I'm an ENT and plastic surgery trained surgeon, and so is Dr. Adam Schaffner. Adam Schaffner is a very, very well-trained surgeon in ENT and plastic surgery as well. He's also involved in a lot of the New York-based political committees in plastic surgery, trying to promote responsible care, education, things of that nature. And he practices out of Manhattan in New York. So welcome, Dr. Schaffner.
Thank you very much.
So, this is an informal gathering. We don't want to make it too wonky or too, kind of academic. It's really a basic level conversation for patients. And I have taken the liberty of jotting down a whole bunch of common questions, at least that I get in my practice, which I'm sure many of you get. And so we wanted to kind of discuss this and get all of your opinions. And, I'm going to pose these questions to the three of you, and I'm going to moderate it. So I'd love to hear you guys on patients' behalf about these questions. So the very first question I think would be interesting to hear all three of your opinions, or just facts really, is that a lot of people ask, I get liposuction done. If I gain weight, does the fat come back? And so I'd love for you guys to just in a very plain, basic way, explain to patients if that's true, and if it's true, what actually happens.
I can start if you like.
Sure.
I think I fielded that question a number of times. One of the nice things about liposuction, or any technique that destroys or removes fat cells, is in a sense it's permanent, because your body really doesn't make any additional fat cells as you go through life. But if you put on weight, the fat has to go somewhere, right? So you've got cells that are in your body that are just waiting for you to eat something, because basically a fat cell is a storage cell. So when you're eating and taking in more calories than you're burning, you have to store it somewhere. So instead of storing in the woodshed, you store it in your fat cells. And when you're burning more calories than you're taking in, you need a reservoir to give you that. So your fat cells start expelling fat and you start burning it for fuel. So there's a really dynamic equilibrium that's going on. But in essence, if you remove a certain percentage of the fat cells, they're gone for good. But there's still plenty of other fat cells remaining that are very willing to accept that and will, enlarge again. So typically, the ideal candidate is someone who isn't overweight. I mean, I've always said that liposuction is not a fat reduction operation. It's really a contouring, shaping operation. It's really for people who are in pretty good shape, who have those isolated collections of fat in the sort of love handle area, or the saddlebag area, or some area that's really difficult to get at. And those patients do very well because they're already in pretty good shape. They have isolated collections of fat, and they have excellent skin tone, which could contract. So from my perspective, it is a permanent operation, but you still have to do work after it, because it's not an excuse to not be in good shape.
So Dr. Levins, so what happens if they do gain weight? Do they gain weight in an abnormal way, and do they have a funny body shape afterwards?
Sure. First, I agree completely with what Joe said. And fat cells, they do expand. We don't grow new fat cells. So absolutely, if they're removed by liposuction, you're not going to get new fat cells in the area, but you still have some fat cells left in that area. So if you gain a lot of weight, you can get some growth of fat cells in the same area. But the idea is that we want to leave a nice contour of fat to avoid irregularities. And we talk a lot about what we leave behind as opposed to what we remove. But typically, if someone gains a few pounds, it's probably not going to make a big deal. If someone gains 10, 20, 30 pounds, or a significant part of their body weight, absolutely, they can have fat cells expand in other parts of the body first. That's where they're going to go to, because there's less resistance there. So for example, if you do the abdomen, the trunk, or all the way around, then they might start seeing something in their arms or their face or their legs if they gain a lot of weight. So I agree completely with Dr. Joe that I try to operate on people that are as close to an ideal body weight as possible. It's really diet resistant fat that we want to remove. It's not a treatment for obesity, although there are some people that operate on much heavier patients that I would like to operate on. I always like it to be a team effort, that they have to do their thing to keep the weight as stable as possible, and I help them to contour what I can, and then hopefully they maintain that and have the best result. So it goes to other areas, basically.
So Dr. Schaffner, Dr. Russo just mentioned it's a body shaping procedure, not really a, kind of a weight reduction procedure, but there's been some literature and, some data that shows that, if you reduce fat in somebody, their lifestyle improves, for example, their diabetes, their hypertension can improve. So is there any indication to do it for other purposes beyond just shaping?
Great question. Thank you. I do agree with everything that both of the doctors had said. Before I answer that question, did want to add one other thing, and that is with regard to the occurrence of weight gain. If someone has had a fat transfer, it's important to let the patients know that the fat behaves like the area from which it came. And so if in fact they would normally gain weight in the abdomen or flanks and you're using that fat to transfer to the breast and buttock, then they will notice an enhancement further with additional weight gain. In answer to your question, Shashi, studies have shown that, and this is not an indication or primary treatment for hypertriglyceridemia or increased white count, but people do get a lower white blood cell count, lower triglycerides in response to liposuction. It has also shown in some cases to be correlated with a reduction in blood sugar and blood pressure. However, it may not be a situation of causation as it is correlation because there's not been direct causal mechanisms associated with that. However, because of the fact that you're debulking someone, helping with shaping and contouring, people feel better about themselves and are more motivated. They sometimes improve their diet, improved exercise regimens, and that results in lower blood sugars because you don't need insulin to transport the glucose into the muscle with exercise. And so you get an increase in, in your metabolism and a lowering in your blood sugar and subsequent lowering in blood pressure.
So, I mean, basically what you're saying is that it has potential to have health benefits, not only physical health benefits, but also emotional and psychological benefits that hopefully motivate people to do better. Because, I mean, right now we're living through COVID and a lot of people are indoors and stuck, and some people are exercising like crazy because they kind of use it as a mechanism to do something, but other people have gained weight. And in my own practice, I've certainly seen an uptick in people coming for shaping procedures. Is that something you guys have seen across your areas in New York, Coral Springs, and also in the Boston area?
New York, absolutely. The 19 for COVID-19 doesn't just stand for that. For those of you who remember the freshman 15, now we got the COVID-19.
I would agree. We certainly have seen an uptick in patients for the very reason you mentioned, that they are sitting around, they're sedentary. They have to spend their money somewhere. They can't go on vacation. They can't go out to eat. They can't go anywhere. So they can invest in themselves. And it seems to be happening in Boston, at least.
The term I've been using is body remodeling and home remodeling, because exactly, people can't spend money on travel. So you see that if you try to get something done in your home, the contractors are very, very busy. And fortunately, all of us, I mean, knock on wood, we're trying to stay healthy, and we are staying pretty busy, which is great.
So technology has come a long way, and understanding of things have come a long way. So, there's a lot of conversation happening in our society about skin contraction after, taking out fat, right? We know, I always talk to patients that, when you do liposuction or lipocontouring, the skin around it has to contract. So what is the best characteristic that the skin should have to get an ideal outcome? And also, are there any new devices that any of you use to augment the result beyond just removing the fat? And one of you guys can start, and I'd love to hear from all three of you, because I'm sure all of us use different devices for various purposes.
I'm happy to start unless one of you guys wants to go first.
Go ahead, Joe.
Go ahead, Dr. Russo, go ahead.
I think one of the big problems with liposuction was its limitations, that when you encountered patients who had skin laxity, pre-existing skin laxity of any sort, I for the most part, disqualified them from liposuction surgery, because I found that when you started removing fat, the skin actually hung to a greater degree and they actually looked worse. So those typical patients who are postpartum patients who had kids and gotten all stretched out, when the skin was hanging, they just weren't liposuction candidates. And so my main determinant as to whether or not someone was a good candidate for surgery was the pre-existing skin tone, right? So I would always just take my hand and pull their skin and see how it snapped back. And then as more devices and top technologies came forward.
So before you go on, Dr. Russo, do you turn them down then actually, or do you recommend something else?
I would turn them down for liposuction, but I might recommend an abdominoplasty or a brachioplasty or something like that, where we actually had to excise skin, because we just didn't have the technology to really give a great result with liposuction alone. And then with the advent of ultrasound and lasers and radio frequency, things started getting better. And I think now we actually have the ability to take those patients that really weren't great liposuction candidates. Now, let me separate that out by saying, when someone comes in with hanging skin already, like the abdominal skin, in my mind, that's really a surgical patient, an abdominal, abdominoplasty, for example, rather than a liposuction patient. But those patients in my mind that are sort of fringe patients that I might have refused liposuction surgery, 5 years ago, I'm now using radio frequency assisted liposuction with an internal and external electrode that allows me to get very precise contraction of the skin with high energy and with really good results. So radio frequency assisted liposuction has taken for me a lot of patients that really weren't good candidates for liposuction and turned them into liposuction candidates. And we've seen really great results with that combination.
So, just so the audience knows, radio frequency is a very commonly used technology in plastic surgery and cosmetic procedures. Radio frequency is an energy source, essentially, that can be delivered through the skin from the top of the skin or delivered directly underneath the skin. And there's different companies that do that, just so you understand. And it's been a very, very common treatment. Nowadays, you can even do radio frequency with microneedling for skin improvement. I don't want to deviate too far from that. I just want to give some context. So Dr. Schaffner, I wanted to ask you, what are the best skin characteristics from an anatomical or a physiological point of view that you believe will give the best results after a lipocontouring procedure?
So I look for someone who has thicker dermis, a lack of stretch marks, does not have a tremendous amount of excess skin, as Joe described. Want to try to find someone who has realistic expectations and doesn't have a lot of wrinkling of the skin, as I describe it to some patients, 80-year-old grandma rice paper skin. When you see people who have had large volume weight loss, weight gain, multiple pregnancies, sometimes steroid use in the past, or other medications which might cause problems with connective tissue, those are people that you have to be concerned with, in my opinion.
Dr. Levins, so in your case, how do you feel about adding, combination things like Dr. Russo just spoke about, adding radio frequency or some other things? How do you feel about that in your practice?
Well, I'm excited. I don't have a lot of experience yet, but I just actually went through looking at the InMode, which is the bipolar radio frequency device that Joe was talking about, external and internal. And I looked at that, and then I looked at the Renuvion device. So Renuvion is internal radio frequency. That's usually typically combined with liposuction, and it's a small probe that's introduced. And I don't have a vast experience, but I'm hopeful that it's going to help me to be able to treat some of the patients that I otherwise would have turned away. I mean, we all know that a woman with multiple births, with stretch marks, loose skin, is going to need a tummy tuck for an optimal result. But then we have patients that are more borderline, that have a little bit of laxity, and rather than just saying, look, I don't think we can do any better with this. I mean, it's really all about expectations. So I certainly don't tell them, and the company doesn't, well, they might promote it as an amazing thing. Whether you get 30% contraction or 40% contraction or 50% contraction, it does take some time. They have to be very patient. And whether it's the two different devices, and then I think there are some other companies as well. I'm hopeful that I'm going to be able to use it for patients that are borderline patients. I think for the neck, and then certain patients for the arm. No one wants to have a big, long scar for a brachioplasty. We all know that if it's a massive weight loss patient with huge bat wings, you can't treat that with a non-excisional procedure. But then you have women that have, or men, just a little bit of laxity, and you're concerned that the liposuction alone will not be sufficient. And so I think adding the radio frequency to it, and the so-called radio frequency assisted liposuction, I think it really has a big place, and I think it's going to grow probably as the technology evolves. So I'm definitely looking forward to. I've started to use it in my practice, and so far so good. We'll see how it goes.
So Dr. Russo, when liposuction first started, many years ago, it's nothing new. It was done manually for the most part, right? And certainly, we've come a long way in technology in general, and now there's a lot of devices that assist us to do liposuction, whether it's with ultrasound or whether it's with electric power of various types. What are your thoughts about using some of these devices, and which one do you particularly like and why?
You hearken me back to a time when we first started doing liposuction. I remember those days because back in those days, believe it or not, it's probably a little before your time. We actually had to have patients give autologous blood because we lost so much blood during our liposuction. We weren't using any epinephrine. These were like in the really early 1990s. And so patients had to give 1-2 units of blood and wait a few months and take iron pills before they could actually have liposuction. And we lost about a third of everything we sucked out was blood. So if we did a 3-liter liposuction, we sucked out 1 liter of blood. And then they still bled for like 24 hours after. So it was really quite a dangerous procedure compared to the way it is now. And just the advent of adding, tumescent liposuction with epinephrine and xylocaine really completely changed the face of liposuction. And it made it not only safer, but essentially that was designed for office use. So it really sort of took the scary part of surgery away. And as time has gone on and we found ways of using different devices, I've tried all the devices. I'm afraid of them all because when I started using the power assistant, for example, I got into so much more bleeding. It brought me back to the days of pre-epinephrine. And I just found it was like too much power to have inside a patient. And when I started using the ultrasound, I started getting burns on the skin and all of these different things. I just felt like I could do such a better job just going back to the way I was always doing, which is just a manual. I mean, I've gotten my fair amount of tendonitis and shoulder injuries, but you know what? I feel like I can deliver the best results to the patient when it's just me, the cannula, and the patient. And I'm just feeling everything. I'm feeling the resistance. I'm feeling the thickness of the skin. So I personally don't like any power or energy inside the patient when I'm doing it. I just feel I'm safer and more comfortable, and I give a better result.
Can I give some feedback on that?
Certainly.
I agree that it's evolved quite a bit. Actually, I don't know, it was probably before the 90s. I mean, because clearly with Dr. Luz, it was a sharp cannula, right? Then we went to blunt cannulas, definitely before most of our time, and possibly no tumescent. It was more of a dry procedure. And now pretty much every technique is tumescent. But I like to tell patients that it's more the operator than the tool, for sure, absolutely. And many of our colleagues and then the companies will promote laser liposuction, tickle. I don't want to give it all away what you're going to ask about, Shashi, but I actually have been using power lately. The last several years, I did go through a Vaser phase, which is the ultrasonic. I definitely don't think it did any skin tightening. I don't think it was particularly selective and helped necessarily with decreasing bruising. It was, a gimmick. The power I do find to help, especially if it's a large liposuction or a secondary liposuction, because of what you're talking about as far as the fatigue, the surgeon fatigue, there's no question. So that's been helpful. And then that's about it. I mean, you can go ahead with the other one, Shashi, because I think the value of laser, and then there's tickle and water, and I really think that a lot of it is gimmicky. So when people used to say, do you do smart liposuction? I would say, no, I do dumb liposuction. I just do the important liposuction and I do what I think I need to do. So that's my statement. Adam, go ahead.
I had my own statement. I used to say, do you do smart lipo? I used to tell patients that I use liposuction very smartly.
There you go. Oh, that's even better. Yes, probably sounds better than dumb lipo. Yeah.
But Dr. Schaffner, you and I are a little bit more contemporary, in our age. So do you have a different view than Dr. Russo, who's a bit older, and Dr. Levins, who's maybe somewhere in the middle? But do you have a different view on different power-assisted devices? Do you think it's the surgeon? Do you think it's the technique? Do you think it's the machine? Do you think it's the patient? Can I give us your feedback on what you use and why?
Well, ultimately, I do think it's the surgeon who is the most important factor in this entire scenario. As I explained to patients, because they all come in asking, what type of lipo do you do? I literally had this happen 3 times today. And so I say that basically everybody uses the tumescent technique, as Joe said and David said. And then I go on to say that there's different flavors of power and different flavors of energy. And so with the energy, we're taking electricity out of the wall, putting it into a box. And whether you're going ahead and turning it into radio frequency or ultrasound or laser or other types of energy, we're using that to heat the tissue, to try to stimulate contraction, and in some cases, quote unquote, melt the fat, although I think you have to go to a very high temperature for that, and the likelihood in most cases is that you're not going that high. With regard to power assistance, there are 2 main players in the United States for that. One is much more dominant than the other. David referenced one of the minor ones here on a volume basis, no pun intended. The point that I did want to go ahead and point out, at least in my experience, and this is with all due respect, as I know Dr. Russo has many more years of experience than I do here, is that in patients who are revision cases who have had a lot of scar tissue, that if I'm trying to do it manually without power, sometimes I feel like that if I try to put too much of my own muscle behind it, I may potentially put the patient at a greater risk for a complication. And so much like an electric knife cuts a tough turkey sometimes, if I go ahead and I'm using power assistance, especially if it's a blunt tip cannula dermal protected, that I'm less at risk for causing a potential problem going through tough tissue. I don't know whether or not you or David or Joe could speak to those types of cases, but that's been my personal experience.
Thank you, Dr. Schaffner. That's very, very helpful. I do use, power assisted, techniques in certain parts of the body. Like, for example, on the abdomen in the front, the fat is typically fairly soft and you don't need a lot of assistance and you can do a fairly good job in a traditional way. But in the upper back area, it's a little bit more thicker and it's harder to kind of manually remove. So I do use it selectively in different cases, and revision cases, certainly, I think that helps for sure. So we talked about safety a bit. Dr. Russo brought it up. So Dr. Schaffner, what kind of concerns should patients have about safety about liposuction or lipocontouring? Because certainly in the news, there's been, at least in South Florida, deaths from this because they're putting it in the buttock and all these sorts of things. We don't want to go to talk about butt augmentation at this point, but just generally speaking, what are some of the concerns or non-concerns, if you do it safely and well, that patients should be aware of?
People certainly are concerned about typical issues associated with anesthesia, bleeding, infection, but most specifically, they are concerned about, from a cosmetic perspective, contour irregularities, dimpling, rippling, skin laxity, and then certainly even if there's no transfer issue, because of some patients' lack of understanding, they bring up some of those stories which you mentioned, which are not only in Florida, but unfortunately have also occurred in New York.
Dr. Russo, what about you? Do you take any special precautions with safety concerns around liposuction and lipocontouring procedures?
In my mind, liposuction is really one of the safest operations we perform. I mean, I think when done with someone who's had adequate training and has proper supervision, it's really very safe. Because if you think about it, we're really staying on the very surface. We're not penetrating the fascia. We're not going into the abdomen or any place where we're potentially going to lose a lot of blood or fluid. So in my mind, in my hands, it's really one of the safest procedures we offer. You don't need a lot of anesthesia because once you put the tumescent in and you've got that local anesthetic effect, you don't really need to deliver a lot of general anesthetic. Patients wake up quickly. They have anesthesia on board for 12, 20, quite a few number of hours, so they're not in pain. So I think the most important thing is after the surgery is putting people in the proper amount of compression, just to take advantage of the fact that there's no bleeding. You've got the epinephrine effect on board. So if you get compression right away, most of our patients have little or no bruising, little or no pain. They're up and around the next day. So, from my perspective, it's really all about going to a person who's done a bunch of them and done them safely, not taking a weekend course, and decided that all of a sudden they were a liposuction surgeon. Because I think that's where the problems happen. I think probably everyone who's here tonight is well trained and has done many of these, and I'm sure feels that it's really, for me, it's a procedure where I relax because I know it's such a safe procedure and I don't really have to think a lot about it. We've done so many and it's very straightforward. So from my mind, it's quite the opposite. It's really not a dangerous procedure and the patient's really quite well protected. But again, it goes back to who's driving the train. The person doing the surgery, as long as they're well trained and competent, then I think there's very little to worry about.
I'm going to throw in a little plug for Symplast here. One of the things I've started doing pretty routinely now is that after every surgery, I do what we call a virtual rounds on them at nighttime. So with Symplast technology, we offer something called a Symplast patient app that almost every surgical patient, every procedural patient in my practice downloads. And we give a lot of post-operative instructions. We give them immediate access to me as a surgeon and also my staff if needed, the very same evening, the next day for follow-up rounds and things of that nature. So the technology has really made a big difference in giving comfort to patients, comfort to patients, and also comfort to the surgeons, honestly, just to check up on people. Are you guys using, what kind of follow-up routine do you guys have, Dr. Levins, for there you go. She's showing a little bit of a screenshot of something that Kaylee put up. But there's a lot of access these days that patients can have to have real transparent, kind of follow-up and communication all through the process. So it really helps us a lot. So Dr. Levins, what type of follow-up or what type of post-operative care does a person need after undergoing such a procedure? Do you need to admit them? Can they go home? Can it be done under local anesthesia? So there's not a lot of downside. Well, how do you manage the post-operative course of these patients?
Absolutely. Well, first I'll echo the use of Symplast for communicating with my patients. We've been users for several years, and it's absolutely one of the best things that we have as far as the mobile ability to stay in touch with a patient. And I actually had been doing phone calls to patients for many years before, but now it's a secure, HIPAA secure communication, so their boyfriend or girlfriend doesn't have to pick up the phone, and they really appreciate it. And that, consistently in reviews, patients say that the doctor's right there. I don't have to use an answering service. I can get to them. And I do the same thing. I give them some instructions. I send them a little video, and not for liposuction, but a little drain care video if it happens to be a tummy tuck that's with drains. But as far as aftercare after liposuction, the best thing about liposuction is, I think we didn't talk so much about patient selection, but I think clearly you can get into more trouble with improper patient selection. So, there's sort of medical complications and cosmetic complications, and we choose the wrong patient that perhaps is really overweight, not motivated at all. They're not going to have a good result. They have a higher perioperative morbidity, and it's a waste of time. Or a patient, very loose skin. But anyway, if you select the right patient and then you go through the surgery, the advantage is they can be active right away, and I want them to be active. So we do put them in a garment, and right away they know they're going to be swollen. Their weight's going to go up a little bit. Don't look at yourself. It takes 6 weeks to 3 months to see the final result. We don't have a definite regimen of post-operative massage, but I have to tell you that there's so much hearsay about post-operative massage. I do remember, is it Dr. Pittman? I think so, in New York. Yes, one of the original liposuction guys, he said, I don't even need to use compression garments. Well, I definitely use compression garments, and I offer people the possibility of going to find some lymphatic massage if they want afterwards, because there's a big push in South Florida, especially the kind of Miami community, that, you have to have massage, and I might not have got a good result because I didn't do massage. But I think massage is probably helpful. I don't think it could hurt. It can be a little painful, but we encourage that. Garment use for 3 to 6 weeks, and then being active as soon as possible. I mean, if someone's gonna have a tummy tuck, they're down for a week or two. With liposuction, after a day or two, they're back to work, and I encourage them to be as active as possible. So that's it, and it's usually pretty straightforward. The cosmetic concerns come up. We're talking about asymmetries, irregularities, whatnot. Those are probably much more common than, I think, serious medical complications, as long as you select the right patient.
So Dr. Schaffner, in your case, do you believe, or do you do these types of procedures under local anesthesia? Can it be done? Is it tolerable? Or do you have to give him some type of twilight anesthesia? Or do you just completely knock him out and give general anesthesia where you put a breathing tube down? How do you think you manage the anesthesia component of it?
I do about 60% of them under local and about 30% IV sedation, 10% general. And when they're done under general, it's done because the anesthesiologist doesn't totally feel comfortable managing it under IV sedation, usually if we're going to be rotating prone. And so that's generally our breakdown right there. For those who are getting it awake, we have a cocktail oral that they receive. They also have the option to use nitrous oxide, Pronox, and we found that to be very helpful. David, you're correct. It was Jerry Pittman. He has since retired. And at least in our practice, manual lymphatic drainage massage, I think, is very helpful. It provides active participation from the patient. It doesn't have to be painful as long as it's done correctly at 5 to 10 millimeters of mercury of pressure. Licensed massage therapist doing true light manual lymphatic drainage, not turning it into a deep tissue massage. That's when it's going to be uncomfortable. For those on the call, important to note, if it is going to be done under a wake case, that doesn't mean you treat it any differently than you would treat a patient under IV sedation or general. Still an accredited operating room, still properly monitored, still with appropriate medical clearance guidelines. Standard of care doesn't change just because it's done when they're awake.
So we've talked about a little bit about safety. We talked a little bit about the preparation, anesthesia, and things of that nature. So when can an average patient expect to see final results? What is the natural course of healing from a procedure like this? Is it a month later they can see, and kind of feel great about it? Or is it going to be a 6 months process? Or what have you guys seen? And does weather make a difference, like in the North versus the South, where in Miami or South Florida versus Boston or New York?
I think it depends on the area being done, the amount of surgery being done, and the number of times that area has been treated. So if I'm dealing with, a first-time person, and let's say it's their abdomen, I usually tell them it'll take at least 3 months to see their final result. If I'm doing an area that's more fibrous, where I've had to work hard, like the flanks or something, I'm talking about 4 months. If it's a redo or an area that has had inadequate liposuction and needs more done, it's probably more like 6 months. And I like to tell patients that because I like them to sort of understand that it is a process. It does take a long time. I also think that in the summer, when your tissues swell, even when you're not having surgery, particularly in Boston, where it's not hot that often, we do see longer healing times in the summer. So I warn them about that too. So maybe they don't want to do it in the summer because for the 3 nice months we had in Boston, you don't want to be wrapped up in a garment and having to stay inside and reducing your activity. So I actually do have them wear the garment for a long time, usually upwards of 3 months or so, or until they feel like, the way I explain it to them is, if you say, Russo's full of hot air and after a month I'm going to get rid of the garment and start exercising and running a marathon, and they come home and they find out that they're really unhappy because they're swollen, I'll say, eventually you'll get to the point where if you wear the garment or if you don't wear the garment, you're not going to see a difference. At that point, you can discontinue it. And it's a little bit different for everybody, and I let them self-discontinue it when they reach that point.
The only thing I would add to that is that the importance, like I was talking about, selecting the right patient, a patient that's motivated, is that my best results are, it's easy when they've lost some weight afterwards. So they're motivated. Maybe they didn't want to go to the gym. Now they're going to the gym or they're working out. I mean, someone that gains weight after liposuction is not going to be happy. So at least maintain their weight or lose a few pounds. And those are the ones with the best results.
So Dr. Schaffner, do you have them weigh themselves during your post-operative visit to kind of chronicle and document how they're doing? Or is that something that, how do you think patients respond to such recommendations?
We weigh every patient every time. We photograph every patient every time. Therefore, it's well documented regarding along their journey. As far as healing time is concerned, I tell patients it's going to be a year. Number one, it provides a long game as far as expectations. Number two, it gives them plenty of time to get diet and exercise in order to hopefully go along the lines of what David was saying. And the third thing, it goes along the lines of wound healing. If you talk about normal wound healing and you look at a curve, you're going to get about 80% of healing at around the 10 to 12 week mark. But we know that you still have about another 20% of healing to go for a course of a year. And we would go ahead and say, well, how does that apply to other things? Well, take a look at a rhinoplasty. If you do a rhino, and this is for us ENT guys here as well, so I'll let Shashi, of course, I want your opinion on this as well. I saw someone else had good nose pictures there. But if you talk about a rhinoplasty, your final result's not at 3 and 6 months. You're going to have skin and soft tissue contracture for many months afterwards. So I think the same is true of the skin and soft tissue contracture after lipo.
Thank you. So this has been, a very lively conversation. If any of the participants have questions they would like to ask, please go ahead and post it here so I could ask the panelists, Dr. Russo, Dr. Levins, and Dr. Schaffner, those questions during the conversation. So it's very informal. So please feel free to post them here, and we can talk about them. So a follow-up question, so Dr. Russo, in your long career, what's the largest what's the largest amount of fat that you've taken out in one session? And do you have a record that you hold, or do you kind of now do as much now, or do you kind of become a little bit more conservative?
I've become a little more conservative, and I'm almost embarrassed to say that I did a 10-liter liposuction when I was relatively young at the game. because, we didn't really know any better, and everything went fine, but I still remember the case.
So for patients to understand, Dr. Russo, what does 10 liters mean, like in terms of pounds? Can you have some kind of metric so they can relate to it?
Yeah. So what I used to say to patients is, if you know what a liter bottle of Coke looks like, well, imagine 10 of those. And not all of that's fat, but a fairly significant percentage is. But I also tell patients, it's not really a weight loss operation. It's a contouring operation. So you're going to lose a lot of inches. You're not going to lose a lot of weight, because fat takes up a lot of volume. It floats on water. It's not very heavy, but it does take up space. So you'll lose, X number of inches from whatever area. So, as I've gotten farther into practice, and I do all of my own surgery at my office surgery center. So, we observe the 5 liter limit. But honestly, I'm finding that most of my suctions are in the 3 liter range, somewhere between 2 and 4. And if I'm getting up to 5, it's usually unusual, but we stop there. But I have set an all-time indoor world's record at 10 liters, and I'm not particularly proud of it. But as I said, it was a long, long time ago before we realized any of the, the dangers that have now become on.
What about you guys, Dr. Schaffner and Dr. Levins? What's your world record so far in your career?
I think I've maybe 5 or 6 liters. That's about it. Probably in the hospital. And that's, I would certainly consider, if I was going to do that large volume removal, I'd want to make sure someone has access to IV hydration and absolutely some monitoring with that kind of volume.
What about New York, Dr. Schaffner?
So I've done 5 to 5.5 a number of times, even under local, but they do get an IV. Anyone who gets over 2 liters of lipoaspirate removed gets an IV and gets at least a liter of fluid. And we'll monitor them for at least an hour. They're getting vitals, et cetera. Again, standard of care doesn't change. 10 liters is impressive. I'm not sure I would have the intestinal fortitude.
That was stupid, but we didn't know any better.
I'm speechless. That's a lot myself.
Yeah.
I've never done that. But
one of our attendees actually just asked, can they have this surgery if they have a hernia or an ostomy?
I'll take that answer. Yeah, well, when we do an examination, I mean, we're talking about the abdominal wall at this point. So all of us, when we do our abdominal examination for a patient, potentially for liposuction or tummy tuck or what have you, we're checking for scars, history of surgery, hernias, masses, et cetera. A hernia by itself is not necessarily a contraindication, but clearly you have to be extremely careful. Dr. Russo mentioned something about staying, actually it was Adam, about staying superficial. And obviously there have been some very, very rare instances of a cannula going into the wrong place, into the abdominal cavity, into the chest. And this is very rare, and with in proper hands, it shouldn't happen with someone paying attention to what they're doing. But if someone has a hernia that you don't know about, that could be easily injured. So you have to avoid that. As far as an ostomy is concerned, I think by itself, it's not necessarily a contraindication, but once again, you're going to be avoiding that area. And as far as there's issues such as infection, we generally have a broad spectrum antibiotic going anyway. And I think that would be something you'd be cautious about, making sure that everything is sealed well at the ostomy and you're staying well away from it as far as a sterile field.
So the follow-up question for this, and I'm going to ask on behalf of the patient, so is there a role for a concerned patient who has a hernia or maybe an ostomy, for example, to get a CT scan or something to understand the anatomy, or is that not necessary in you guys' opinion?
I think it sounds like a very reasonable idea, whether a CT or an MRI of the abdominal wall. Certainly if there's some issue, I mean, yes, it's, I don't think it's mandatory, but it's certainly reasonable if you have questions about the magnitude of it.
There's a couple other questions here. One of the questions here is that, is there ever a role to place a drain after liposuction? Do any of you, I've had some colleagues tell me that they do, some other colleagues have said no. So what do you guys do? And is there a certain level of liposuction that you have to do to get somebody to get a drain?
I've never placed a drain for lipo, but we do go ahead and milk all of the areas at the conclusion. We also go ahead and, as I said, do the manual lymphatic drainage massage, compression garment immediately thereafter. So thankfully, I've never had to do that. In my now 11 years of doing this, I've only had one patient who had a seroma. It was of a woman who had a revision case. Ironically, she was a physician.
Hold on, Dr. Schaffner. A seroma, just so the audience understands again, because it's a medical term. I just want to make sure. Could you explain what a seroma is for the audience?
A non-infectious, non-blood-based fluid collection based on fluid that is either a combination of that left behind and or fluid from which the body is creating in response to inflammation for wound healing in a closed area. So it could be like in the thigh or the belly region, in the subcutaneous area, in the area between the skin and the deeper tissue. But your body in a given area generally can only resorb about 30 cc's in a 24-hour period. If there's more than that, then the fluid's going to hang out and it's got to get removed somehow. And that's where a drain may come in, or doing a tap like an aspiration.
What about you guys, Dr. Russo, Dr. Levins? Do you put a drain in or no?
I do not.
I've never used drains, but I did work with a surgeon who put 5 or 6 drains in routinely. I thought it was barbaric and looked awful, and it was hard for the patients to move, but I've never done it either.
I haven't used drains, but I will say that I have had a couple of, it's been 31 years for me, Adam. You look very young. But I certainly have had a couple of seromas, typically in the lower back, because especially if you're working on the sacral area and you want to try to create a nice contour there, it just seems to be an area where, for whatever reason, the planes get involved. And so fortunately, it responds very well to aspiration if needed, and then a good compression garment. But I've had a few seromas in that area that fortunately respond to needle aspiration, and then maybe once or twice and some good compression and it goes away. But I don't usually preventatively put a drain in.
So I'm going to ask one particular audience member asked 3 questions. So I'm going to try to combine them so we can there's a lot of good discussion going on here. So if you have darker skin tones, is there any problem with scarring with liposuction because of the darker skin tone for African Americans, or maybe pigmented skin types? And if they have any comorbid conditions like hypertension and things of that nature because of their ethnic background, is there a contraindication to doing such a procedure? What are you guys' thoughts about that?
I will say, in a darker skin patient, anytime you make an incision on the skin, there's a significant chance for hyperpigmentation. And if the patient's prone to that, and they'll know if they're prone to that. After the surgery, I would start them on some sort of bleaching cream, hydroquinone, something that stops the pigmentation from forming. With respect to hypertension or any other metabolic disorder, that's really an anesthetic issue. If they have significant hypertension, it has to be controlled. If it's well controlled and it's not a risk for surgery, that's all fine. But I don't think that changes anything. Either you're healthy enough for surgery or you're not. So the fact that you have a pre-existing condition is not an absolute contraindication to surgery. It's just, is it controlled and how dangerous is it? Those would be my only considerations.
Yeah, I'm pretty sure you guys agree with that analysis as well, is that, many patients come to us with many types of medical conditions. And if you're well-trained, if you're very thoughtful with proper care, you can manage most patients well, with proper precautions. Would you guys agree with that general statement?
Absolutely, yes.
Yeah. And then also for liposuction scarring specifically, the incisions are fairly small in general, so it's not a huge concern, and we always try to place it in a place that hides it well. But is there any scarring of the tissues itself beyond the incision? Like, do you get any kind of abnormal scarring of the liposuction area that creates contour irregularities, in you guys' opinion?
You can, and that's the reason for deep tissue massage once you're not having the need for manual lymphatic drainage massage.
Okay, well, great. So very good question. Another one is that how long after a procedure like this, we talked about this briefly, you can go back to activity in a day or two, perhaps go back to work in a day or two. You can wear a garment. Nobody needs to know that you had anything done at all, and it doesn't have to show. But how soon can you actually physically work out? Like, go for a run, lift weights, etc. How many weeks do you guys generally tell them not to or to do it, for example?
I don't usually restrict people very long at all. I usually let them use their judgment. I mean, with the compression garment, basically what you're trying to do is you're trying to avoid shearing between the soft tissues and the underlying muscle and fascia. And if they have a good compression garment on, they're going to know, and you can kind of, let pain be your guide. People have kind of a numbing or strange or whatever feeling. So if they're a runner, then they're just going to start walking in the beginning. They may not go running for, as Adam said, the 6-week period of wound healing. I don't know that people have to do nothing for 6 weeks, but just gradually build up so that maybe they're waiting that long to avoid the shearing effect and the discomfort. I don't see it as a big problem in terms of, messing up the effects of liposuction. so much more than messing up the results when we do an excisional procedure with scar spreading and issues like that. So I'm pretty liberal about letting people get back to activities quickly.
What about you, Dr. Schaffner and Dr. Russo? Is there any particular time you tell them not to exercise vigorously beyond walking and doing day-to-day activities?
Go ahead, Adam.
I traditionally tell them 2 to 3 weeks, start slow, work your way up as tolerated, and then go from there. If they start feeling that there's any pain or they notice significant swelling or asymmetry, call immediately. And then the one other thing I did want to comment on, the individual who asked about darker skin tones. They're also, in addition to post-inflammatory hyperpigmentation that Joe referenced, also whether it's African American, Asian, or Latino, with darker Fitzpatrick skin types, you need to be concerned about monitoring for keloid or hypertrophic scars.
Okay. Well, this is a very good question. We talked about this a little bit, radio frequency based question. So, what are some of the risks associated with the radio frequency specifically? When you apply that, with liposuction or without liposuction. Dr. Russo, I think you've done a fair bit of radiofrequency treatments. Why don't you take that one first?
For a long time. One of the nice things about radiofrequency is it's colorblind. It doesn't matter what skin type you are. There's no increased danger if your skin's a little bit darker or lighter. And if you're using a device that's a smart device, which maybe turns off when you reach a certain temperature, there's really very little risk associated with it. There are devices that are not temperature controlled, that don't shut off, automatically when you reach a certain temperature. So they require a greater degree of monitoring externally and internally, perhaps. So the risk of burning the skin is always a potential risk. But I would say, with respect to radiofrequency's position relative to all the other technologies, I think it's one of the safest. I think it's one of the safest and most effective, given the fact that you really are adding quite a bit of heat to the skin. I think what needs the sort of audience needs to understand is that up until recently, all of the radiofrequency was delivered externally, like you were talking about. And the limitation of external radiofrequency is the same as laser or ultrasound or anything. When you get the temperature of the skin up to a certain point, maybe over 40, 41, 42 degrees centigrade, it just hurts too much and you have to stop. I mean, patients have different levels of tolerance, but very few people can tolerate it over 40 degrees centigrade for a very long period of time. So just when you get to the point where you want to be, you have to stop. And that limitation has been universal. But when you are able to combine radiofrequency with a technique like the tumescent technique that we were talking about earlier, and you can bring the temperature up to whatever range you want it and hold it there for as long as you want it without injuring the patient, that changes the game for me. So I think it's very safe and very effective.
I agree.
So we use RFAL. Just a couple of pointers for those who haven't used it. Realize that while definitely agree with Joe's statements, you can get a burn. I have seen burns, and use the external FLIR camera if you have that, in addition to the monitoring from the internal and external temperature probe. Also recognize that you do not want to have your foot on the pedal as you come out of the site, because you can get a burn at the site if you don't disengage the system first. Also realize you can get a heat sink, which is the accumulation of heat internally. And so therefore you can get a delayed onset burn. So some key pointers there. Lastly, they do market it as a bipolar, but it's not a true bipolar. It's actually sesame polar, because it's basically has a probe internal and external, where the heat comes from internal, goes to external. But because it's not actually going between the two probes like in a true bipolar, they technically call it sesame polar, according to the physicist who wrote the original papers on it there.
So another good question that came up is that, one of the audience members asked, do you have to do lipocontouring or shaping all over the body to get a good outcome, or can you do it one or two problematic areas and still get a good outcome, or is it very patient dependent with an examination and understanding of the goals?
I think it's patient dependent. I mean, really, people, some people say that, they want the doctor to say, you should do this, you should do that. I let the patient speak for themselves. What area bothers them the most, and then we prioritize. But it seems like they have more than you can do in one session. You might break it up. But, there's some people that just have their neck done, just their arm done, just their abdomen done, just their thighs, or a couple together. And as long as a reasonable amount of of time in the operating room and a reasonable amount of fat being removed, you can combine several areas, but you certainly could be very selective and just do small areas. So I think it's really patient dependent.
I would agree with that. What do you guys think, Dr. Russo and Dr. Schaffner? Any additional thoughts beyond that?
Go ahead, Adam.
I pretty much agree with David. When somebody comes to the office and says, "What do you think you can do for me?" Turn it around and say,
Loaded question.
Turn it around and say, "Well, what bothers you most?" There's lots of things that I may see. There's lots of things that I may be able to do. That doesn't mean that we should do them. And if you start suggesting something, one classic example is Cindy Crawford with her mole, or Sarah Jessica Parker with the nose, and et cetera. There are certain classic traits that some people have that are very famous that may not meet aesthetic ideals according to the textbook, but they may like or want to preserve. So I would strongly encourage people to turn that question around and say, "I'm here to help you. Tell me what bothers you most, and I will give you best suggestions on how I can best get there."
Great. So a couple of, this is great. Lots of good questions. So one of the questions somebody asked is that, do you close the openings or the incisions that are made to do the procedure? Do you guys put stitches there? Do they have to be removed, etc.? So Dr. Russo, do you leave them open to drain out, or if they drain out, do they get all messy, or what happens?
When I was first trained, I was trained to leave them open. And once I finished training, I've never left one open. I closed all of them. I actually started using buried interrupted sutures. And I just found that it was problematic for the patient. So I just use like a Proline, a 5-0 or Proline or 6-0 Proline, depending on the area, take them out a week later. And I just find that to be better for the patients and better for me.
Okay, so for the audience members, so it's essentially no internal sutures in your case, only external sutures that have to be removed in a few days.
Yes, 6 weeks or 6 days or so.
Yeah. Do you guys close, Dr. Levins and Dr. Schaffner?
Same for me, but I do also a nylon or a Proline, a 5-0, one simple stitch about a week later. The leakage issue is definitely something that happens. So it depends on how much fluid goes in, how much lipoaspirate comes out. But we put on some, pretty good dressings, some ABD pads, and I tell all the patients, please put some towels down, some sheets down. Expect that either in the car on the way home or when you get home, you're going to see something that looks scary, and realize that after a day or two, it's going to dry up. You can take your garment off, take a shower, and it's fine. But if they're not told about that, then they can get very nervous about seeing the bloody drainage come out of the incisions, because they're not watertight clothes, and you expect them to be absorbed and then some of it to drain out. So that's very common.
Yeah, so this leads to the next very logical question is that, if they are going to get messy and you do put a garment on, do you give them more than one garment? Is it expensive? How do patients go about, managing the costs associated with the extra garments, etc.? What do you think, Dr. Schaffner?
I'm sorry, the connection got broken up there for a second. So can you repeat the last part of the question?
Yeah, the question basically is that, we're talking about closing or opening those little incisions that may have drainage. And if there's a lot of drainage and the garments or the compression garments that, get messy and they have to wear it for an extended period of time, do you generally provide more than one garment to the patients, or do they buy it on their own? Does it get expensive? How do you manage it?
We offer all patients to buy a second garment if they would like to. If they don't want to, we tell them that they can go ahead while they're in the shower, wash the garment, air dry it, don't put it on heat because we don't want to shrink it. And then, if they're out of the garment for an hour, 2 hours, after they've already had it on continuously for 24 to 48 hours, I don't think it's going to be a huge situation.
Yeah, some of this is, again, surgeon dependent, I'm sure, and then how you package it into the whole operation cost. You can maybe factor in 2 of them, 3 of them, what depends, and also offer patients to order some in if they want extra ones that, we can order as a physician, or they can buy on their own these days. I think there's a lot of sites there that patients can go to. One of the other questions or chat on the chat box that came out is that, is the 5 liters or 7 liters or 3 liters, is it in one area or the overall body? And I think, one of you guys answered, but I just want the other audience members to know that typically when we talk about the volume of removal, it's usually the whole body or the whole operation content, and not just in one location. is the typical answer. So guys, it's coming up on 1 hour. I don't want to say it's a weekday, it's late, it's 9:30 on East Coast. I'm sure we got to get back to families, but it's been a great conversation. We've had a lot of participants, had a lot of great questions. I encourage all the participants to tune back in again next month. Symplast is going to be hosting these once a month with reputable surgeons all across the country, so that we get unbiased, good information, because these days, every Instagram post, every Facebook post, every marketing channel has so much information, it kind of gets a bit messy. So one of the goals that I hope to have is to kind of at least give some curated content that you guys can all utilize. And please remember the names: Dr. Adam Schaffner from New York, and Dr. David Levins from South Florida and Coral Springs, and Dr. Russo from Boston, if you guys want to check them out. So I think there's another chat here before all the information. So I'm so excited for my upcoming surgery. I don't know who you're seeing, Lisa, but good luck with your surgery. Thank you for joining. Any last questions do you guys have?
Dr. Levins, it's your patient.
There you go.
Oh, okay, great, excellent.
So another audience member, Vinicia, says, thank you, surgeons. You're very, very welcome. We enjoy it. As you can see, this is our life. We are surgeons, and we think about this and do this night and day, and we try to provide the best service that we can to all of our patient base. So Kaylee, it's over to you. You're on mute, Kaylee, I think.
I am, and I apologize for doing that. I was going to follow up with what you said, and thank you all for joining us. You made our second Symplast Physicians educational webinar a success. So much great, high quality information. Your opinions were all definitely valued, and you gave such good insights to all of your patients, or future patients that have joined us. So we really appreciate it. And if anyone in the audience was a little shy and didn't want to have any of their questions put out there, you're more than welcome to reach out to anyone with your questions. You can, if you have any questions about Symplast or what we do, feel free to email us at hello@Symplast, and we can get you any information that you need. So thank you all so much for joining us again. I know it's been a long hour, and I hope you all have a great rest of your night and an even better weekend. So thank you, and we'll see you next time.
Thank you, and happy
Thank you very
Thanksgiving
much.
to everybody.
Thanks,
Stay safe.
Dave. Thanks, Adam. Good night.
Good night, guys.
Here.